Good morning, and thank you for joining us for this latest video in our series of showcasing AF Pioneers of 2023 as part of the AF Association Healthcare Pioneers Report. I'd like to introduce Mr. Tony Grayson now from Inspira Health, and he's going to present his case study on a national programme to optimise anticoagulation in patients with atrial fibrillation. Tony, over to you.
Thank you very much. Okay, so I'm Anthony Grayson and I work for Inspira Health, and I'm here to present a national programme to optimise anticoagulation in patients with atrial fibrillation. This was a programme that involved Inspira Health, Daiichi Sankyo and NHS England. Just get conflicts of interest out of the way. Obviously, I'm a member of Inspira Health and I did receive funding from Daiichi Sankyo for setup costs and staff salaries. In terms of background for the piece of work, we know that there's a wide variety of anticoagulants available for atrial fibrillation patients, but we also know that not everyone that needs to be anticoagulated gets that anticoagulation, and it's roughly about 1/5 of high-risk patients that remain untreated. It is important, though, that these patients are treated, and it's part of the NHS long-term plan to ensure patients receive anticoagulation therapy where possible. And it's estimated that about in every 100 people that we treat with anticoagulants, that we'll save 4 strokes. In terms of the objective of the piece of work, it's pretty simple. We wanted to make sure that anyone with atrial fibrillation was appropriately anticoagulated with the primary goal of reducing strokes. Primary care networks were invited to apply for funding from NHS England to undertake the primary care atrial fibrillation service, which is Inspira Health's PCAF service. But to be eligible, you had to be in the top 2 national quartiles for 2 particular indicators, which was diagnosed AF but untreated and estimated undiagnosed AF patients. And these indicators come from a combination of Quality Outcomes Framework and Public Health England data. The PCAF service is delivered through 5 key phases. Step 1 being the creation of patient lists and identification of anyone who has atrial fibrillation. Step 2 involves a comprehensive clinical audit of the patient's medical records, looking at those patients who are not currently anticoagulated, trying to figure out whether they need to be or not. Also looking at patients who are on warfarin therapy and assessing whether they're optimally managed or whether they'd be better suited on an alternative medication, but also assessing patients on DOAC therapy, ensuring that they're on the right dose and on the best and appropriate medication for them. Step 3, once the audit's completed, involves inviting patients to participate in telephone consultations, and this would either be with a consultant cardiologist, a nurse specialist, or a clinical pharmacist, depending on availability of the healthcare professionals. Step 4 would be the clinics themselves, where the healthcare professional would discuss with the patient about any necessary changes to their medical therapy that is required and the risks and benefits of that. And then step 5, always an important one but can be overlooked, is the follow-up aspect of the service, which ensures that we make sure that all actions that have been agreed with the patient are actually carried out and patients are getting the appropriate medication they should be. Once GP practices have been signed up to the programme, they sign up to a detailed clinical protocol, which they're able to understand all the ins and outs of what's going to be delivered as part of the service. And we also sign off GDPR and data protection regulations, a very important aspect of the service in terms of agreeing data protection impact assessment and signing off the confidentiality agreement. Communication is also important in the delivery of the programme. We have a series of patient letters that are shared back and forth between ourselves and the practice, and any changes to wording that they feel necessary can be made to these documents, because the communications are going to their patients. But these communications inform the patient that they're being invited to partake in a telephone consultation, but also after the fact remind them of any medication changes that have been agreed, and they also get some information shared with them to explain the reasons behind why this is being done. We also have a preemptive text that goes out beforehand, before any invitations get sent out, letting patients know that medications are being reviewed, and they have an opportunity at that point to opt out of any reviews. To help with communication, we have a dedicated patient advisory telephone line, and this is agreed beforehand with GP practices, and any communications with patients include this telephone number, so patients are able to phone us to discuss any concerns they may have, seek any clarifications, reassurances, and report any side effects for any medications that they may have commenced from the service. This is very much appreciated by the patients and the GP practices, because trying to get through in a timely manner to GP practices at this particular moment in time can require a bit of a wait. But if they phone the patient advisory telephone line, it's manned all the time, and the majority, 98% of calls, get answered first time. And then we strive to ensure that we phone patients back within 15 minutes if we've not been able to take the call beforehand. It's a dedicated line, so it's very focused on anything that these patients have got concerns about, and we log any conversations with patients in their medical record, and if there are any changes needed, i.e. prescriptions changing for these patients, we task the GPs accordingly to carry out those changes. In terms of the results, so we've managed to complete the service across 85 primary care networks across England, which involved 351 GP practices with a population of just over 4 million patients. And that was with an AF prevalence of 2.9%. Prior to the audit, just over 11, nearly 12% of patients with AF weren't on any form of anticoagulation. Still a fairly sizable number of patients. Just over 10% were on vitamin K antagonists medication, predominantly warfarin, and the bulk of patients were on DOAC medication. So there was nearly 91,000 patients on that medication. Overall, in total, we had 88.2% that were already being anticoagulated. Other key results then from the service, we found that 1 in 5 patients who weren't on anticoagulation required DOAC prescribing, and these patients agreed to that. So 20% started anticoagulation at that point. 13.7% of warfarin patients had suboptimal TTRs and agreed to change to DOAC medication. A smallish percentage, but still reasonably big in the grand scheme of things, 4.3%, so nearly 4,000 patients who were already on DOAC had their dose change to ensure that they have the appropriate protection against AF-related stroke. And just less than 50% of DOAC patients were changed over to an alternative DOAC in line with NHS England guidelines. With all these changes that were undertaken with medication, our anticipated outcomes from the service are estimated to be around 337 AF-related stroke admissions avoided, and we'd expect around 200 lives saved. And in terms of finances that go alongside that, we'd expect just over £8 million worth of savings in terms of avoided stroke admissions, and just over £13 million saved in terms of drugs budget from the changes to DOAC medication, which gives a anticipated total savings to the NHS of £21 million. We received patient feedback and practice feedback during the service. Always important to take this, and we found that the patient satisfaction score was 4.8 out of 5, and practice satisfaction was 4.7 out of 5. Still very good scores indeed. So in conclusion, we had a national programme to optimise anticoagulation in AF patients, and we found that this reduced the risk of stroke and led to significant cost savings to the NHS. But just one final note is that the methodology used to deliver the PCAF service can be replicated and delivered to other healthcare conditions, for example, heart failure, cardiorenal metabolic conditions, cholesterol management, just as examples. Thank you very much.
Thank you very much, Mr. Grayson, for a fantastic presentation of the case study. What I think it's highlighted as well through the case study is sort of the importance of anticoagulation. So why do you think some AF patients are still not being prescribed anticoagulants to reduce their risk of an AF-related stroke? So as the AF Association, we get a lot of people who are advised to take aspirin, for example, despite the guidelines not saying that. So why do you think that we're not sort of getting the anticoagulants and being recommended in this situation?
So there's a variety of reasons. One thing I will say before I go into the reasons is that we've found that over the years, it is a lot better. It is significantly better. You know, the education that GPs have received has definitely improved their approach to anticoagulation. And I think most GPs, the majority, are a lot more confident now in prescribing DOAC medication in particular. But one of the key reasons why patients who've got atrial fibrillation aren't on the appropriate medication is partly because it's a very historical diagnosis that's been made maybe a number of years ago. The patient may have obviously had some concerns starting an anticoagulant. So there's some element of patient reluctance, if you like. And one of the key drivers why I think patients end up on aspirin rather than DOAC medication, for example, is because that risk of bleeding is still a key driver in persuading people to make a less aggressive strategy, if you like, on getting patients on this medication. But I think overall it's certainly improving. And to get it to improve even further, we just need to continue with the education and making sure that people understand, making the right decision about whether, to start them or not. And if in doubt, cardiologists should be consulted for advice and guidance, and they can help definitely.
I think what you said there is going to reassure a lot of people, Tony. And once again, I'd like to thank you for your time in submitting a case study for the Showcasing AF Pioneers of 2023. And again, thank you for an excellent presentation and great. Thanks very much.
My pleasure. Thank you very much.